The chapter we're going to review now is on pre-op and post-op care. It begins with preoperative assessment, and we're going to review only the situations that really would make an operation very hazardous to do, because I think it's important you'll be able to recognize those on an exam. So we begin with a little bit about the assessment of cardiac risk. Let me read vignette number 1. A 72-year-old man with a history of multiple myocardial infarctions is scheduled to have an elective sigmoid resection for diverticular disease. A preoperative radionuclide ventriculography shows an ejection fraction of less than 0.35. Now, this is a no-go situation. The normal ejection fraction is 0.55, and you want to be the closer you can to that for a person to undergo an operation. But if it is less than 0.35, the risk is extremely high that this person would have a myocardial infarction during or shortly after the operation, and the mortality for that infarction would be very high. So you ought to find an answer for this vignette where the disease the patient has is managed in a different manner rather than doing an operation. Now we move to vignette number 2. A 72-year-old chronically bedridden man is being considered for emergency cholecystectomy for acute cholecystitis that is not responding to medical management. He had a transmural myocardial infarction 4 months ago, currently has atrial fibrillation, 8 to 10 premature ventricular beats per minute, and jugular venous distension. Let me tell you what this vignette is all about. There was a gentleman by the name of Goldman who took the trouble of compiling all of the findings we may see on a patient that predict cardiac complications during non-cardiac surgery. These are referred to as Goldman's criteria, and I gave you all of them in this vignette. So let me go over them again. 72-year-old, obviously there is a higher risk for an older patient. Chronically bedridden, there is a higher risk if the individual is not active. Being considered for emergency cholecystectomy, the risk is typically higher in an emergency operation versus elective, and also higher if you have to enter a body cavity, like the abdomen in this case. He had a myocardial infarction 4 months ago. That adds to the risk. A recent MI is bad news when it comes to doing elective surgery. He has atrial fibrillation, which again is bad, premature ventricular beats, which is bad, and jugular venous distension, which in this case signifies he is in failure. And so if you had this vignette on the exam, you would realize that it would be absolutely foolish to even think of operating a man like this. And so you again would look for an answer where his problem, in this case the acute cholecystitis, is managed differently. And in fact, my suggestion here would be a percutaneous cholecystostomy. This is done by the radiologist, going right through the liver. They drain the contents of the gallbladder, and they buy time. They take care of the acute problem without subjecting the patient to the risk of an operation that he certainly would not be able to tolerate. I'm going to now repeat some of these, because there are a number of these findings that all by themselves are good predictors of risk, and you might have vignettes that only give you that one. Let's read vignette 3. A 72-year-old man is scheduled to have an elective sigmoid resection for diverticular disease. In the preoperative evaluation, it is noted that he has venous jugular distension. This is bad news. Venous jugular distension in this setting. Now, this is not a trauma patient where the distended veins would lead you to think pericardial tamponade or tension pneumo. This is simply a patient with heart disease. That jugular venous distension signifies the patient is in congestive failure right now. If we operate a patient when he is in congestive failure, the risk is very high. But fortunately, we have treatment for congestive failure. So the thing to do in this gentleman is to medically get him out of failure. And you could do that with ACE inhibitors, beta blockers, digitalis, and diuretics. And once that has been accomplished, then he could have the operation with a much better risk. Vignette number 4 is another version of the same theme. A 72-year-old man is scheduled to have an elective sigmoid resection for diverticular disease. In the preoperative evaluation, it is ascertained that he had a transmural myocardial infarction 2 months ago. Let me review this with you. If a patient has a myocardial infarction on Monday, and I operate on that patient on Tuesday, I kill him. But on the other hand, if a patient had a myocardial infarction 2 years ago, and now I operate on him, his risk is no different than if he had never had a myocardial infarction. So you see the issue, the key issue is time. How soon after the MI are we planning to do our operation? The closer you are to the time the patient had the MI, the higher the risk. As a rule, we prefer, if at all possible, to wait 6 months. This would be the answer you're looking for. If there is an option here that says, you know, manage the condition medically until 6 months have gone by and then you operate on the patient, you could do it with a very reasonable risk. Obviously, there will be cases where you cannot wait 6 months and you might have to do it at 2 or 3 or 4 months after the MI. But ideally, you want to wait 6 months if you can do it. And vignette number 5 is another version of a condition that you would rather not operate the way things are, but you could improve the situation before we operate. A 72-year-old man who needs to have elective repair of a large abdominal aortic aneurysm has a history of severe progressive angina. Well, now, in this case, it would make sense to first evaluate him as a candidate for coronary revascularization. And we will talk about those details when we have the chapter on cardiothoracic surgery. But if this man is a good candidate for revascularization, if that is done first and then his aneurysm is operated on, the operation for the aneurysm then can be done with a much better risk. We now move on to pulmonary risk. Let me give you a little background before we read the vignette. As a rule, when we're talking about pulmonary risk in a surgical patient, we're talking about somebody who smoked an awful lot, who has COPD, and whose problem is going to be ventilation rather than oxygenation. Let me read the vignette. A 61-year-old man with a 60-pack-year smoking history and physical evidence of chronic obstructive pulmonary disease, COPD, needs elective surgical repair of an abdominal aortic aneurysm. He currently smokes 1 pack per day. If you operate that man right now, as things are, he would have a pretty high risk. So let's first evaluate how bad is his COPD. And there are going to 2 tests that you're going to do. You're going to start with pulmonary function studies where you pay particular attention to FEV1, forced expiratory volume at 1 second. If that one is abnormal, then you do blood gases and you pay attention to PCO2 because, as I pointed out, the problem is going to be ventilation rather than oxygenation. If both of these are abnormal, FEV1 and PCO2, it'd be better not to operate right now. The patient could be convinced to stop smoking, ideally for 8 weeks. You provide intensive respiratory therapy, physical therapy, expectorants, incentive spirometry, etc. And then you might be able to operate on him when his FEV1 and his PCO2 have improved. Let me point out, by the way, that if you're evaluating this gentleman and his FEV1 is normal, don't bother to do the blood gases because they will also be normal. The FEV1 goes wrong before the blood gases become abnormal. We now move from pulmonary risk to hepatic risk. And actually, it's going to be a sort of a bottom line that I can put at the beginning. We need good liver function to tolerate an anesthetic and an operation. Let me read vignette 7. A cirrhotic is bleeding from a duodenal ulcer. Surgical intervention is being considered. His bilirubin is 3.5, his prothrombin time is 22 seconds, his serum albumin is 2.5, and he has encephalopathy. And if you operate this man, you kill him on the table, because he's got all kinds of laboratory indication of severe liver dysfunction. This man has to be treated in a different way. And in fact, my suggestion would be for this bleeding duodenal ulcer that he get an arteriogram and arteriographic embolization, so you can take care of the problem without killing him in the process. But any one of these parameters alone, if significantly above normal, would contraindicate an operation. Let me read you a few quick vignettes. A cirrhotic with a blood ammonia concentration above 150 needs an operation. He better not get it. A cirrhotic with an albumin level below 2 needs an operation. Boy, that risk would be exceedingly high. Here are a few examples then where these individual parameters may contraindicate surgery. Vignette number 8. A cirrhotic with a blood ammonia concentration above 150 needs an operation. He better not have it. A cirrhotic with an albumin level below 2 needs an operation. Boy, the risk would be extremely high. It's even high if it is below 3, but below 2, terrible. And vignette number 10, a cirrhotic with a bilirubin above 4 needs an operation. Now on this one, though, I have to make an additional observation, because I have operated many patients during my career that had a bilirubin of 25. But that was due to obstruction of the biliary tract. So the implication of a vignette I just read is not that if a patient looks yellow, he's not a surgical candidate. You can operate on a patient with a high level of bilirubin in the blood if that doesn't signify liver disease. But if bilirubin as low as 4, like we pointed out, if it is due to hepatic dysfunction, it really contraindicates the operation. The patient would probably die. We now move to nutritional risk. Vignette number 11. An elderly gentleman needs palliative surgery for a cancer of the esophagus. He has lost 20% of his body weight over the past 2 months, and his serum albumin is 2.7. Further testing reveals allergy to injected skin test antigens and a serum transferrin level of less than 200. Every one of those numbers that I read are ways we measure nutritional deficiency, and this individual is severely malnourished. Let me go over them again. He's lost 20% of his body weight over 2 months. Boy, that's bad news. If somebody loses 20% of body weight over a year, they can adapt to that. But if you lose 20% of your body weight in a short period of time, like 2 months, you cannot. The serum albumin is below 3, 2.7. That indicates severe malnutrition. And the energy is another indicator, as is the level of serum transferrin. Now, what do we do then with this patient? Well, the answer might surprise you. Now, you know intuitively then that this individual is a very bad risk because he's severely malnourished, and that you should not operate on him right now. You would, however, expect that if he got this badly over a period of a few months, that it would take a few months to get him back to normal, but he doesn't. Surprisingly, as little as 5 days, preferably 10, but as little as 5 days of intensive nutritional support, preferably delivered into the GI tract rather than TPN, you can regain a great deal of the nutritional integrity of this person. So the answer you're looking for on the exam on this vignette would read intensive nutritional support delivered to the GI tract for anywhere between 5 and 10 days. And finally, the last of the examples of preoperative assessment has to do with a metabolic condition, vignette number 12. An elderly diabetic man presents with a clinical picture of acute cholecystitis that has been present for 3 days. He's profoundly dehydrated, in coma, has a blood sugar of 950, severe acidosis, and ketone bodies all over the place. Now, ladies and gentlemen, you cannot operate a patient like this. You absolutely cannot. If a patient is in diabetic ketoacidosis, the diabetic ketoacidosis has to be treated first. Now, I'm not proposing that you spend 2 or 3 days doing that, because during that time his gallbladder condition could kill him. But at least a few hours have to be spent rehydrating the patient with an insulin drip to begin to lower his serum glucose concentration, correct his acidosis, and once the parameters are closer to normal, the operation can then be done safely. Well, this concludes the preoperative assessment.